Greetings and welcome to Living with CLL, a live telephone and web education program. At this time, all participants are in a listen-only mode. If you are participating by telephone and require assistance during the teleconference, please press *0 on your telephone keypad. It is now my pleasure to introduce your moderator, Lizette Figueroa Rivera. Thank you. You may begin.
Hello, everyone. On behalf of the Leukemia and Lymphoma Society, a warm welcome to all of you. We have over 1,300 people participating from across the United States, as well as other countries, including Canada, India, Iraq, and Portugal. Special thanks to Dr. Stephen Spurgeon for sharing his time and expertise with us today. Before we begin, I'd like to introduce Kristen Furman Simmons, an LLS volunteer policy advocate and a caregiver for her father who is living with CLL. Kristen, please go ahead.
My name is Kristen Furman Simmons, and I am from the great state of Maine. I have been part of the LLS community since 2012, when my dad was first diagnosed with CLL. I've been a team captain with Team in Training for 8 years, and I overlapped that time with LLS as a volunteer policy advocate. But in my most important role, I've been a caregiver to my father, who has, as I mentioned, CLL. I've learned a great deal about this disease and its treatments. I've watched as my father has battled CLL, and I know how this diagnosis can impact a patient, their family, and the entire community that surrounds them. Having a loved one diagnosed with blood cancer can be extremely difficult. And I know that the information that my family and I have gathered throughout the years has assisted us in being better advocates for my father. I'm also an advocate for LLS, and it's the stories that help bring the data and research to life for our state and federal policymakers. This has been hugely meaningful work to me and, of course, patients around the country. We've really been able to make an impact. I want to welcome you to this program where a key opinion leader, Dr. Spurgeon, will provide us with the most current information about CLL and its treatments. We're fortunate to have Dr. Spurgeon speak to us today about the latest advancements for CLL. So much has happened just in the past 10 years that my dad has been diagnosed, and it's very exciting news. Also, as a caregiver, I wanted to let you know that LLS will also be providing us with education and support. On June 9th, alongside a healthcare professional, I'll be featured in a webinar especially for CLL caregivers, where we'll focus on self-care. And then on June 16th, LLS will have a caregiver question and answer session called Caregiving Over Coffee. I know you know this, but LLS sees the value in providing education and support to both patients and caregivers. Thanks again to LLS, the leading source of free blood cancer information and a leader in advocating for patients and their families, helping us to navigate cancer treatments and ensuring that we have access to quality, affordable, and coordinated care. Back to you, Lizette.
Thank you, Kristen, for your welcoming remarks, and we look forward to hearing more of your story next month at our Caregiving for CLL webinar. For this program, we would like to acknowledge and thank Genentech and Biogen, Eli Lilly and Company, and Pharmacyclics, an AbbVie company, and Janssen Biotech for their support. If you are participating in this program on a computer, Dr. Spurgeon's slides will display as you listen to the program. You can also view or print the slides from our website at www.lls.org/programs, or you can download and print the slides from the Event Resource tab on this program's web platform. The closed captioning option is available on the left side of your screen. It is located underneath the Ask a Question section. Following the presentation, we will take questions from the audience. I am now pleased to introduce Dr. Stephen E. Spurgeon, Associate Professor of Medicine, School of Medicine at Oregon Health and Science University, Hematology Oncology in Portland, Oregon. On behalf of the Leukemia and Lymphoma Society, thank you for volunteering your time and expertise with us, Dr. Spurgeon, and I now am privileged to turn the program over to you. Dr. Spurgeon, you're muted.
Well, you'd think after 2 years of a pandemic, we'd figure out the mute button. But thanks to all of you for joining. I was just saying that it's so wonderful to be part of the LLS community and such a strong network of CLL patients. So thanks to Lizette and thanks for Kristen for that patient support overview. I always like starting with this. This is a patient of mine from about 12 years ago when I was working at the VA that was a musician. And this is what he called this leukemia in E-flat major, and this is what he thought his blood looked like. And as you'll see from the next slide, it's actually not that far off. So it's just always a reminder of, many people are living with this and viewing it in different ways. So today we have a number of things to cover, some of which will be more basic for some of you. Some of it will be over other people's heads, and that's okay. This is a chance to get to know some of the nomenclature and some of the issues that I get asked about every day in clinic, and then I encourage all of you to ask questions afterwards. So we'll be talking about just a brief background and disease overview, and then we'll focus on the, quote, best initial therapy. There are different approaches to the disease with pros and cons. We'll also talk about minimal residual disease, which has become front and center in the treatment of CLL as a treatment outcome. Briefly on the next wave of therapeutics, there are many. And then no talk will be complete right now without a mention of CLL and the COVID pandemic. So in chronic lymphocytic leukemia, as a way of background, is the most common type of leukemia in Western countries and is actually rare in Asia for unclear reasons. But it's characterized by an uncontrolled proliferation of our B lymphocytes, or B cells, which is a type of white blood cell within the peripheral blood, lymphoid tissue, and bone marrow. This results in severe immune dysfunction. So one way I like to look at this disease is that it is an immune disease. Remember, B cells are a type of white blood cell, and they're critical to the immune system. So we know that CLL patients that are a higher risk of infection, and over the course of the disease, that's continued to be one of the main challenges. On the left here, you can see what our normal blood looks like. A neutrophil is a type of white blood cell that fights bacterial infections. And there you can see red blood cells and monocytes. And monocytes, actually, in the context of CLL, support the CLL cell. They are not a CLL cell, but they actually provide protection for the CLL cell, and in that context are called nurse-like cells. On the right panel, you can see the leukemia cells that are a little bigger than a red blood cell, and that's what we would see if we looked on a blood smear. So I always like to think about this when we're talking to patients about, what is happening and what's happening in the bone marrow to produce these cells. Remember, the bone marrow is the organ that makes all of our blood cells. And you start with a blood stem cell, and you get a myeloid stem cell and a lymphoid stem cell. The myeloid stem cells give rise to red blood cells, which carry oxygen throughout the body. They give rise to platelets, which help the blood clot. And they give rise to myeloblasts, which form certain white blood cells, in particular neutrophils, which are of interest. On the other side, we have lymphoid stem cells, where we get a lymphoblast and we get B lymphocytes and T lymphocytes. So when we talk about an issue of BCLL or CLL, it's in this pathway that something goes awry and we develop CLL. This is a little bit more involved slide here, and this highlights sort of how our normal B lymphocytes work. So we all have B lymphocytes, and when we get a vaccine or we see a viral infection, that activates the B cell. And that B cell then becomes a memory B cell that recognizes that specific insult. So for example, my flu shot from 2 years ago was a specific flu shot. And when I got that flu shot, the B cells expand and they adjust their receptors to recognize that specific insult. And if we queried my body today, we would be able to find a cohort of memory B cells that recognize that specific insult. So that is essential for immune function. Now, what happens is after you get expansion of those cells, they then die back, and you have many, many populations. As you can imagine, every sort of insult we've ever seen, from a viral standpoint or infectious standpoint, we've developed some degree of memory B cells. And this assumes that your immune system is intact. Well, CLL has really sort of co-opted this mechanism. So if you look here, you have the stem cell I just mentioned on the last slide. It becomes a pro-B cell, a pre-B cell, immature, and then a mature. And as you can see, you start developing a B cell receptor along the way, and this is the part that actually recognizes the specific insult or virus or vaccine or what we call antigen. And what will happen is that will then come out of the bone marrow, and these cells will go into the lymph nodes where they will adjust or mutate this B cell receptor. And what will happen when they mutate the B cell receptor, it's mutated so it's specific to that antigen again. So whatever that flu shot was, you have a specific population from the B cell mutation. And what you're left with is some mutated cells and unmutated cells. So in CLL, this process happens where some go on and become mutated CLL at this B cell receptor, what's called the IgHV, and others go on to develop unmutated CLL. Now, why am I mentioning this? Well, they're very different biologically, and we'll talk about that when it comes to therapy. But this really sort of speaks to the idea of how normal B cells work and how CLL cells work. So, for example, if I take an unmutated CLL cell and I take it to my laboratory and I stimulate the B cell receptor, it will activate and make more cells. Conversely, if I take the mutated CLL cell, it's as though it's already mutated and seen that insult, and it'll sit there dormant and not really recognize that antigen or that triggering activator. And the reason that is relevant is because you can imagine that an unmutated CLL is much more active and more promiscuous, if you will, and is more likely to become active and make new CLL cells, where a mutated CLL cell in the body typically is more slow growing, makes fewer progeny cells. So how can we use that in our understanding to come up with therapies and move the field? Well, this is the old model of CLL. So when I was coming up as a fellow, this is what we learned. We said we had a CLL cell, we had a B cell receptor that I displayed in that last slide, and we had way too much protein called BCL2. BCL2 is a protein that keeps the cells from dying or undergoing apoptosis. So if you have too much BCL2, these cells are inappropriately resistant to death, cell death, because as we know from sloughing skin cells and things like that cell death is very important, and it's equally as important as cell birth. So what the old model was, the CLL cells would just accumulate because there's too much BCL2, and they had limited activity of the B cell receptor, meaning not much was going on to activate that B cell receptor to make new cells. So this is the current model, and this is much more reality as we've gotten better molecular techniques to understand. And I won't belabor the points, but you can see it's a complex interplay between nurse-like cells, which are monocytes, bone marrow cells, and activation of the B cell receptor, interaction with T cells, and very active enzymes that promote cell growth and activation. So it turns out this is not a static old model, but instead it's a model that is very dynamic. And in fact, it really has co-opted this B cell machinery inappropriately. So unlike a normal B cell, which will just be sitting there inert, waiting for that insult to come along, these cells may have a very active B cell receptor at rest, at baseline, and that gets activation of these various enzymes. But what that allows us to do, it allows us to target the cell. So if you have an active enzyme on which the CLL relies for cell survival, you can knock it out with certain drugs. At the same time, we now have drugs that block BCL2 that increase the ability for the cells to die. And we also have many things that can target cell surface markers, including CD20 antibodies such as obinutuzumab and rituximab. As you'll see, I'll be throwing around a lot of names here, and hopefully they become familiar by the end of the talk. So what are the clinical manifestations of CLL? Many of you on the call have experienced these things, and that can be swollen lymph nodes, early satiety or left upper quadrant fullness. So of course, patients don't come in saying they have early satiety. They say, well, when I eat, I have to eat smaller meals. And that's because if the spleen gets enlarged, these CLL cells like to go into the spleen. And if that happens, it's next to the stomach, so people have to eat smaller meals. They may describe fatigue from the disease expanding, or also from anemia, weight loss, fever, night sweats, recurrent infections, more rarely bleeding if platelets are low, and then autoimmune phenomenon where these cells inappropriately produce antibodies that target the red cells and the platelets for destruction. So here's an example of some enlarged lymph nodes in the neck. Now, many patients nowadays will present just with an abnormal blood count. They will not have lymph nodes that comes to the attention of their physician. But many patients will go on and say, well, I noticed a lump over here the other day, and lo and behold, a biopsy shows that it's consistent with CLL. Here's another example of enlarged lymph node in the armpit. How symptomatic these lymph nodes become really depends on where they are. You can imagine there's a lot more room for growth in the armpit than there would be, back here behind the head, because there's not a lot of expansive room to grow. Patients may have what we call the Pato Splenomegaly. So these CLL cells, in addition to going to lymph nodes, like to go to the liver and the spleen. So the liver is over here on the right side. This is a gentleman from many years ago, actually, that I took from a textbook that had very advanced CLL. And on the left side is the enlarged spleen. So that's something we're always looking for when we're examining patients. So I think the thing to remember is that CLL is characterized by immune dysfunction. And it's the simple way I like to think of this is, as you get more CLL cells around, you have a bigger population of non-functioning B lymphocytes. And really that crowds out the activity of your other immune cells. So it's not just, you have these increased B cells, you have these increased T cells, but they don't work properly. And so you can't, when it says impaired antigen presentation, that means when you see that virus or that viral protein, it's blind to it, nothing happens. You also have decreased antibodies. You have a chronic inflammation, which creates an immunosuppressive state, and a number of other defects that really impair the immune system. So I think the key thing here, and we'll talk more about COVID, and some of this is beyond the scope of this talk, but at diagnosis, I always like to make sure that people are up to date on their vaccines. And this is true whether they're 25 or 85. So we always vaccinate for pneumonia with the Prevnar vaccine and the PPV23 or the Pneumovax. We vaccinate for shingles, the Shingrix vaccine. Of course, we vaccinate for COVID with 4 vaccines, and no live virus vaccines are permitted. We also give immunoglobulin or intravenous immunoglobulin for those patients that have low immunoglobulin levels and recurrent infections. And then we also give antivirals in anyone getting active therapy. So if you do start therapy, these are the things you want to think about. And then you want to make sure you get your vaccines before you start therapy, because that's usually when your immune system is the most robust. So a couple of things to consider when we're seeing patients is cytopenias just means low blood counts, anemia and thrombocytopenia, or low hemoglobin and low platelets. And that's really from a number of things. That can be marrow infiltration from CLL. It can be anemia of chronic disease from inflammation. It can be destruction. It can be immune destruction in the bone marrow of red blood cells, or it can be marrow suppression from treatment. And we also want to think about if someone has an indolent course or slow-growing disease and then comes in with very aggressive growth of lymph nodes or just feeling horrible, we sometimes need to think that the CLL has transformed to something more aggressive. We also need to think about secondary malignancies. The immune system is imperative for immune surveillance against malignancies. And so it's as though the immune system has blinders on. And so you may have an abnormal skin cell that someone who is immunocompetent may recognize, the cell may recognize, but in this case, the immune system is blind. And so you're at slightly increased risk for other cancers. So we definitely recommend increased skin exams and cancer screening. Now, this panel on the right shows a normal bone marrow. As we age, it gets replaced by fat, like many other things. And one can see why someone might have low blood counts, because this is a marrow full of CLL. So all those blue cells represent CLL cells. And so when you have that, you can't grow your normal red cells or normal platelets. And I think the simple analogy is your marrow is like a healthy garden, and it gets overrun with weeds. And obviously you can't grow your healthy garden back until you take care of those weeds. So what are some things we look at when we're working at patients to understand their risk factors? So we have the B cell receptor. I mentioned mutated and unmutated. The unmutated is unfavorable and mutated is favorable. And that's because, again, the unmutated are more likely to be immature and recognize a broad range of signals to become stimulated. We also look at FISH and cytogenetics. And basically, when we think about FISH and, sorry, this is the B cell receptor with the hypervariable region I'm talking about that gets mutated up here on the surface of the B cell. We also look at FISH and cytogenetics, which has been long-standing. In fact, the seminal paper was now in around 2000. And you can see that basically what we do, and by we, I mean the pathologists, who are experts in this field, they will mark the cells and they have probes for the chromosome. So here's a cell, and normally we have 2 copies of each chromosome. But in this case, this person has an extra copy of chromosome 12, which can be one of the recurring themes in CLL, and that's called trisomy 12. So there is a whole CLL FISH panel we get, but importantly, in this day and age with our new therapies, the key things that are 17p deletion, so you're missing part of chromosome 17, and if someone has more than 3 abnormalities within their panel of chromosomes, those are considered high risk. So I think some key treatment principles going in. We know that standard therapy is not curative. So our goal is to knock back the treatment and give people long remissions and normal life and a normal life expectancy. We also know that the absolute white count number is not used for treatment. Instead, the rate of change is. So I often have patients that come in and say, what is the absolute white count? I must be treated. And that varies for each patient. So you can imagine if someone comes in with a white count of 150, a normal white count's about 11 or 11,000. If someone comes with a white count of 150, and these are all cancerous lymphocytes or CLL cells, if they've taken 10 years to get to that point, often they don't need treatment. It's as though the body's been able to adapt. It hasn't harmed the other systems, and the disease is not really active. However, if they come in with a white count of 150 that's gone that way in a span of 2 years, they often will need treatment. So the rate of change is very important. We know that therapy reduces symptoms. We know that therapy has side effects, and it can alter the types of infections seen. And then we also know the current model is we treat when people meet IWCLL treatment criteria. So that's with enlarged lymph nodes, symptomatic enlarged spleen, low blood counts, or what we call B symptoms, which might be fevers or weight loss. So typically, most people, when they're diagnosed, are approached with a watch and wait. We know that it's a rapidly evolving treatment landscape. So the old approach really was DNA damaging chemotherapy was the king. So chemotherapy hit every DNA of every dividing cell and was really not targeted. And the biggest problem there is it eventually stops working. It's one mechanism of action, essentially, and over time the cells outsmart the chemotherapy, and there is increased risk of long-term toxicity. I mention these agents here because these are agents that have traditionally been used for the treatment of CLL. Classically, Cytoxan and chlorambucil have been around many, many years, many decades, and have been the mainstay of CLL treatment for a long time. Then we developed and I use we very loosely, developed purine nucleoside analogs, including fludarabine, and more recently, bendamustine. And FCR, which is fludarabine, Cytoxan, and Rituxan, as well as bendamustine, have been the most commonly used agents over the course of CLL chemotherapy treatment. However, as I showed that slide, we've been able to leverage our understanding of the disease pathophysiology to develop new targeted agents. So chemotherapy is largely obsolete. We like to inhibit the B-cell receptor pathway. We like to target the BCL2 protein. We like to use immune-based therapy. And really our motto now is really spare the DNA, if you can, of normal cells. So these are some important drugs. BTK inhibitors, so that BTK, Bruton's tyrosine kinase, is an important enzyme in CLL signaling. It gets activated when the B-cell receptor is activated. And in CLL cells, remember, it's inappropriately activated most of the time. So we have drugs, ibrutinib and acalabrutinib, and more recent zanubrutinib, which inhibit that. We also have Pi3 kinase inhibitors. Pi3 kinase pathway is also activated in CLL, and we have drugs idelalisib and duvelisib. BCL2 inhibitors, we have venetoclax, and anti-CD20 monoclonal antibodies, rituximab and obinutuzumab. Now, these are drugs that come in and target the outside of the cell, and they activate the immune system to kill the cell. So this is really a form of immunotherapy. We know that these are effective in upfront and relapse treatment settings, and we know they're superior to chemotherapy. So the question then becomes, do we want to do continuous therapy or fixed duration therapy? And in fact, when we first started developing these new drugs, we thought, gosh, here are some oral drugs that overall are pretty well tolerated, work differently, and maybe we can manage this like hypertension. The challenge has been the cost of these drugs, and any drug has potential side effects. So as we've learned more about them, the pendulum has shifted back. Well, do we really have to continue these drugs indefinitely? So what is the best initial therapy? And now this is, in my opinion, you may get other opinions if you talk to other CLL specialists. The real question is, watchful waiting still the best option at diagnosis? Is there any role for chemotherapy? MRD negativity, minimal residual disease, what is that? And is that a treatment goal we need to think about? And if we're going to do ongoing continuous therapy with a BTK inhibitor like acalabrutinib or ibrutinib, which one do we use? Do we use in combination? Does this really need to continue forever? And then what about fixed duration therapy? Is our goal achieving MRD negativity? And so I wanted to touch on these things. And one of the hardest things when someone is diagnosed is watchful waiting, or much more aptly put, watchful worrying. It's really hard to come in and see your oncologist and have them say you've got a blood cancer and, we'll see you later. But that's based on the fact that original data, it is older data with older chemotherapy. There was a trend towards doing worse in people that got treated out of the gates. So because of that, the IWCLL treatment criteria really are based on symptoms and active disease. And that's also based on the fact that about a quarter of people with CLL, their disease will be so slow growing or indolent that they actually never need treatment. So of course, if we could identify a high-risk subset that would benefit from earlier treatment, that would be great. Is there anything we can do with our new therapies that might impact the disease? Now, when we first started, there was a trial that was accruing in the early 2000s that went to patients with what we thought was higher risk disease who were asymptomatic. And we went to them and said, well, you can either get this chemotherapy with this huge list of side effects, or you can just continue on the golf course every day without coming in for treatment. And so not surprisingly, that trial it had to close down because patients weren't interested in that trial. So as we've gotten better therapies, though, we can really challenge that paradigm again. Obviously, you want to pick the high-risk patients to decide, do these patients need watchful waiting, or should they be treated early? And so there is a high-risk disease score called the CLL International Prognostic Index, which is made up of age greater than 65, advanced stage, something called beta-2 microglobulin, which is a lab test, blood test, an unmutated IGHV, or a 17p deletion or p53 mutation. And here you can see the breakout of why this is. This is basically a couple different cohorts. One is a cohort that is developed and the other is a test cohort where the actual model is applied. You can see on these axes, which I'll continue to show during this talk, the y-axis you see time to first treatment, the x-axis is time in months. You can see patients that are low risk, watch and wait patients, don't need treatment for a long time. And in fact, some very low risk patients, in this cohort of 120 months didn't yet need treatment. So you didn't even get a median time to treatment. Conversely, intermediate risk patients, so those that had 2 to 3 of these risk factors, you can see needed treatment on average of about 48 months. Then if you go into high risk and very high risk, these two, you can see these patients needed treatment quickly. So, and this held true on any data set that was examined. So the question is, can we use this to really define what patients might benefit from early treatment? And there have been some studies. This is a study from Germany. The Germans are very active in CLL. They took low-risk patients and high-risk patients. EFS is event-free survival, which basically means, is their disease progressing, or do they need treatment, or is there some sort of medical event? Overall survival is just that, are these patients still alive over time? So again, we have that on the y-axis. We have the number of patients that are still event-free, or the number of patients, or proportion of patients that are still alive. And on the left panel, you can see the patients that are low risk and watch and wait. Again, they do quite well. These are patients that were not intervened upon with chemotherapy. Conversely, these other patients got FCR chemotherapy, which we don't do as much anymore for the reasons I mentioned earlier. And yes, here you can see they haven't progressed. And if they're observed, they progress. But we know that anyway, right? So the question is this really changing the natural history of the disease? Or is it better to treat these people when they need treatment? So yes, these patients needed treatment, and they needed treatment if they were high risk, between years 1 and 2 on average. But then if we look at overall survival, we don't see a difference. Now, we don't have lots of long-term follow-up, but it seems that with FCR chemotherapy early on with a high-risk group, understanding that FCR is an inferior treatment now, that these patients had the same survival whether they were observed and then treated, or they got chemotherapy right out of the gates. So then the question was asked, well, what if we use ibrutinib? That's a much better tolerated treatment. And we take patients with high-risk disease at increased risk of progression, and we randomize them to treatment with ibrutinib versus placebo. And you can see event-free survival. Again, people that got the treatment, they did well. They didn't progress. Well, that makes sense. They were on active treatment. The people not on active treatment progressed. We also know that their high-risk groups seem to do better than the historical high-risk groups. So as one of my colleagues pointed out, this is a positive answer to a poorly phrased question. This does not answer the question of really deferred treatment, waiting until patients really need treatment after a period of observation, but instead says, yeah, our treatment works. Of course, if you use it earlier, it's going to help. So this didn't really answer much of a question. Importantly, there's a study going on in the United States. It's an NCI-sponsored study. There are places open throughout the country. And this is the idea of trying to answer the question that this study did not. This is early treatment versus late treatment. So high-risk patients get treated early at diagnosis, or they get treated per standard, where they get treated later when they meet treatment criteria. And it looks at overall survival and quality of life outcomes. So patients who are diagnosed out of the gates, if they are interested in clinical trials, and I hope everyone gets more knowledge about clinical trials, they can have the disease characterized early on and see if they're eligible for this study. So is watchful waiting still the best option? Yes, unless on study. Is there any role for chemotherapy? Well, okay. let's see. Current data would suggest there's a very limited role of chemotherapy. So these are two very important studies that compared ibrutinib-based treatment, remember, our oral targeted therapy, plus rituximab, that anti-CD20 antibody, with FCR. And you can see that the benefit was ibrutinib outperformed FCR. It was superior in terms of the progression-free time. So really, that was largely the trial used to adapt ibrutinib over chemotherapy up front. That is also true with the Alliance trial in older patients, which also use ibrutinib or ibrutinib Rituxan versus bendamustine Rituxan. And PFS is progression-free survival. And here you can see that the progression-free survival at the time someone was in remission was significantly better than patients that got ibrutinib versus the standard chemotherapy. The exception is patients with really good risk disease didn't seem to do any better with the ibrutinib chemotherapy as compared to FCR. This is another trial looking at FCR. This is from the UK that looked at FCR compared to ibrutinib and really found the same thing. The progression-free survival, so this is shown here. This is the FCR group, and this is the ibrutinib Rituxan group. And the ibrutinib Rituxan group had a longer time of remission. Where now remember, this is ongoing treatment, where the FCR people just get 6 months of treatment. But you can see ongoing that they had a significantly longer remission. So not just in the United States, but also internationally has this been seen. So I would say generally any role for chemotherapy, nope, and we'll come to more of that with Venetoclax-based treatment. So the big thing that has come up, ibrutinib has been a game changer for CLL. This is a drug that really changed our ability to salvage patients' disease, even though they had progressed on chemotherapy. So it really has been a game changer. But the question is, can we improve on ibrutinib? And for the first time, we've always thought this would be the answer, but really we have definitive evidence that I think the answer is yes. So on the left side, when we think about these targeted drugs, the targeted drugs are exactly that. They have a specific target that we try to knock out. But like anything else, when you're trying to target something, there can be collateral damage. And in this case, collateral damage is it's hitting other enzymes off target. So this is what's called a kinome scan, where you can actually measure the affinity of the drug in terms of concentration for given kinases. Now, ibrutinib, what you can see is, yes, it targets BTK, but it's kind of a relatively dirty drug, meaning it hits some other kinases. Now, of course, when we first saw the efficacy of this, we thought, well, is that one reason it works so well is because it not just targets BTK, but maybe there's some off-target effects that can be beneficial. But then a couple other drugs came along, acalabrutinib and zanubrutinib, and they have the same mechanism of action, essentially, with a little different properties. But they too target BTK, but they have fewer off-target effects. So the question is, were these better drugs, or they were just going to be Me Too drugs like another antihypertensive medicine? And we could see that across studies, the side effects we care about most were lower in the patients that got the second generation BTK inhibitors, acalabrutinib and zanubrutinib. The things we really care most about when we're seeing these patients, obviously there are quality of life side effects that are critical, like arthralgias, such as joint aches. Those seem to be lower in patients getting the second generation. Diarrhea seems to be lower. Now, a lot of these things may happen out of the gates, but we can control over time. But the big things that can be very difficult over time is hypertension and atrial fibrillation. So we know that these things hypertension can be increased in patients on BTK inhibitors, as can the risk of atrial fibrillation, which is a non-life-threatening heart arrhythmia. And more recently, other arrhythmias have shown to be important. Here you can see that hypertension is definitely lower in acalabrutinib and zanubrutinib, as is atrial fibrillation. One thing unique to acalabrutinib is headache. So about more than a third of patients will have a significant headache, especially during the first month, that typically can be controlled with Tylenol and caffeine. So it looks like these drugs are not me-too drugs, but the only way to settle that is through a randomized clinical trial. And this is a trial that compared ibrutinib to acalabrutinib in the relapse setting called Elevate Relapse Refractory. This just shows the type of patients that came into the study. They were higher risk patients, whether they had the 17p deletion, yes or no. And they were randomized to acalabrutinib or ibrutinib ongoing, with the primary endpoint is, are these the same? Is one non-inferior to the other? And then secondary endpoints is, what are the side effects? So you can see identical. They performed identical. This is progression-free survival on the y-axis, and on the x-axis, months of progression-free time. And they were identical, equally as effective. But as far as the secondary endpoints, this is, I think, what we were most excited about. The rates of atrial fibrillation were significantly lower in the acalabrutinib arm at 9% versus 16% in the ibrutinib arm. Also, we saw that there was more hypertension with ibrutinib, and there was a little more higher rate of inflammation of the lungs, which can happen rarely with these drugs. Now, one thing to point out is this was not a blinded study, so both the physicians and the patients knew what they were taking, so there could be a little bias there. However, it does look like the acalabrutinib is better tolerated. Importantly, if you look over time, this is the percentage of events looking at hypertension or high blood pressure. And ibrutinib, there were significantly more hypertensive events over time. It does seem to plateau after a certain period of time. Most of these people, and that's because most of these people, we've picked it up by then and started antihypertensive treatment. This is any cardiac event. So any cardiac event as well, you can see that the ibrutinib had a higher rate of any cardiac event. And importantly, this is a trial we've participated in. We don't have analysis, but there was a press release that showed that the responses of zanubrutinib, another second-generation BTK inhibitor, showed a very good response, overall response. It showed a very good progression-free survival, seemed to be superior to ibrutinib. And importantly, lower rates of discontinuation. Typically, this is due to side effects, and a low rate of atrial fibrillation, things that are all important for us and our patients. So the question is, what do you do if you're on a drug like ibrutinib or acalabrutinib or zanubrutinib, which zanubrutinib is not yet FDA approved for CLL, but if you're on these drugs and you develop a side effect, what do you do? Well, often it depends when someone develops a side effect. So if it's early in the course of treatment and the disease is not under good control yet, we can often switch to another BTK inhibitor, and that can be tolerated because, as I mentioned, they're not exactly the same. So if you look at about a third of people that get treated with ibrutinib and then retreated do not get recurrence of that we call adverse event, AE, when they get retreated with acalabrutinib. So typically in that setting, we take people off the ibrutinib, let them recover quickly from any side effect, and restart the next BTK inhibitor, acalabrutinib. Now, let's say someone's been on ibrutinib for 2 years and develops atrial fibrillation, and their disease is under good control. Often in that situation, we just stop and observe for a period of time. The same thing can happen if someone doesn't tolerate acalabrutinib, you can switch them to ibrutinib and they may tolerate ibrutinib. So there is a class effect, but often we need to do some trial and error. If someone doesn't tolerate one BTK inhibitor, they need to go on to the next. Excuse me here. Okay. This question comes up all the time in clinic. Well, I'm on this drug that costs $14,000 a month. You've told me it's a great drug. I've been on it for 3 years. I'm tolerating it well. Do I really need to do this? Do I really need to continue? I'm on Medicare. It's got a big copay, et cetera, et cetera. And unfortunately, there aren't as much data as we'd hope, and it's more anecdotal data from our experiences. But I think increasingly this is an area of interest in something that has been studied. Now, there was an initial study that came out that said if you held your ibrutinib for more than 8 days, you were more likely to progress over time. So this is a group from the NCI, the National Cancer Institute, that basically looked at patients who missed their ibrutinib within 6 months of treatment and then missed ibrutinib within a year of treatment. Now, they used that 8-day threshold because that's what had been described. But they also said that about half the patients had held it more than 15 days. Now, this doesn't necessarily answer the question, can I stop indefinitely? But I think the point is, if you look at the progression, people progressing over time that hold their drug within the first 6 months for some reason, or if they hold their drug within that first year for some reason, there is no different in outcomes. So we run into this all the time because not only do people want to stop the drug in some cases, many times more likely people are afraid to stop the drug because they're worried that the disease is going to take off while they're holding the drug. With rare exception, this is not nothing to be worried about. If you need to hold the drug, we can hold the drug and restart it. Often it needs to be held for surgeries. It may need to be held for side effects. It may need to be dose reduced. And this data would suggest that we're not doing any harm if we do that. I would point out that some patients, especially with relapse disease, when they go out, control of their disease becomes very dependent on that BTK enzyme and the B-cell receptor pathway. So sometimes when we discontinue the drug, people can get a rapid flare that's manifests as fever. It manifests as rising lab parameters and just feeling lousy. And so sometimes we learn that the hard way, but there are ways to mitigate that. So what about stopping ibrutinib, more indefinitely? Well, this is a trial that begins to address this question. And I'm sorry, this is what's called a swimmer's plot. These are each individual patients treated over time. The way this study was designed was to say, well, you make it to 36 months and you've had a response, you can go off of the ibrutinib. Now, as you can see, these bars here, these are all patients that went off ibrutinib, many of whom went off for other reasons. They didn't get to the planned point. There are other people that stopped per protocol. So all these shaded areas are people that came off of ibrutinib. Now you can see they haven't been off ibrutinib that long, and the follow-up is only 8 months. But of those people, there are only a few purple dots. The purple dots are progression. So this person progressed on the drug. These two progressed off the drug. And so you can see that only 2 of the 13 patients had progressed while off the drug after having had a good response. We see this in the clinic as well. So some people that have had really good responses over time, you can give them a treatment holiday. It's just not well described in the literature. So, whoops, that was what happened there. Okay, so any role for chemotherapy? I would say not really. Ongoing treatment with single agent BTK inhibitor. Which BTK? At this point, I favor acalabrutinib, understanding that sometimes I need to switch to ibrutinib. Also understanding that if patients are tolerating ibrutinib currently, I do not stop and switch to acalabrutinib. So if you're already on ibrutinib and it's effective and you're tolerating it well, I would continue. If you're not tolerating it, I would talk to your doctor about the possibility of switching to acalabrutinib as long as it's still working. I'm not really going to touch on the combination aspect today. But what about treatment interruption? Perhaps, I think overall, again, if you're needing to stop treatment for a period of time in the first 6 months to a year, that's okay. And even later in the course of the disease, I would say generally the standard of care remains continuous therapy, but if you have to stop the drug or really say, I'm tired of this cost, the quality of life is not what I want it to be, I think it's reasonable to have that discussion with your doctor to go off the drug. What about MRD negativity as a treatment goal? So minimal residual disease, this is the idea, and here's some links here if you want to watch that. Actually, one link I came across is a guy that was in Paris at a museum that the art exhibit was him actually literally trying to find a needle in the haystack. So that's one of the links. But the second link is a link from a company called Adaptive that does a lot of this work. Really outlines, it's a 2-minute video. I'm sorry I couldn't import it here, but it really outlines the idea of what minimal residual disease is. But essentially, it really is like a needle in a haystack. So if each one of those pieces of hay represents a cell, we're trying to find one cancer cell within that stack. Because you can imagine the deeper the remission, the fewer cancer cells, the longer the remission. And as our platforms have gotten better and our technologies have gotten better, we can really search for this in real time. First of all, minimal residual disease, this approach really isn't applicable in patients getting BTK inhibitors. We do know though, dating back to FCR chemotherapy, that MRD negativity is associated with longer remissions when we give fixed duration therapy. So if we give therapy for 3 months and people are MRD negative, meaning you can't find a single CLL cell using our most sensitive techniques, or whether it's 6 months, 8 months, if you're MRD negative, you tend to have a longer remission. So really it's the question, is that our goal? So initially there was something called multicolor flow cytometry, where you run these cells through a special device with fluorescently identified markers that can bind to cells and light up in certain gates, so we can recognize, are these CLL cells or not, or are they just normal other white blood cells or B lymphocytes. And so classically, we've had a sensitivity of 1 in 10,000 cells in the bone marrow, which has been the gold standard. And again, we know that MRD negative outcomes the same no matter how you get there. So the question is, what is the best platform to use? Flow cytometry or next-gen sequencing? And then what do I do with this information? It's all over the place about MRD, but what does it really mean? Should I be talking to my doctor about it? And should I monitor this serially? I mean, so I'm MRD negative now, we can't find any cancer cells. Does that mean I should get this test every 3 months? So I think the key thing to understand here is we're able to identify, and you need to get a sample pre-treatment, because everyone's CLL has unique markers on it based on essentially the B cell receptor and how different parts are exchanged. And that's specific sequences. So what we can do is identify specific genetic sequences in the cancer cells that we can track over time. And this is highly sensitive. So this is what we call next-gen sequencing and not multicolor flow cytometry. But the reason this is nice is that it is more sensitive than the multicolor flow cytometry. And what that means, it allows us to use the bone marrow. We don't have to do bone marrows in people to understand this, where the gold standard before was in the marrow. So as an example, 60% of people may have negative multicolor flow, but a positive clonoSEQ test or next-gen sequencing test. And you can see here also they may have so this is the depth of detection as well. So I think the key thing here is that whether it's bone marrow or blood, you can see they operate the same way, and that here you can see that MRD is detectable in the bone marrow or all these patients in a very predictable way, and in the peripheral blood. So how do I use this? Well, again, I mentioned that it's really not applicable to patients getting ibrutinib or acalabrutinib or zanubrutinib, because that drug is designed to control the disease, not fully eradicate the disease. And that's why it requires continuous therapy. MRD is really used best when you're doing a fixed duration aggressive, I shouldn't say aggressive, but more a treatment that is more likely to kill all the disease. And so the way we use this is a patient of mine who's on Venetoclax, which is highly potent and given for a finite or fixed duration period. And here you can see at the start, this is the tracking high level of MRD, which is what we expect because a high level of disease. And as we treat over time, we can see that clone or that CLL population come down. So what do I do with this? I actually use it to see if I can stop treatment early, because some patients will achieve MRD negativity early. Why predispose them to a longer treatment course if they don't need it? And then I also use it to see, are things dynamic? Are they changing? So here's an example. Well, I had a pretty good response, but look, it's still coming down. And it's now less than 10 to the minus 4, which is outstanding. Only less than 1 in 10,000 CLL cells can be identified. And perhaps with ongoing treatment, it'll go even deeper. So the idea is if it's deeper, someone can get a longer remission. Conversely, let's say this person's response had plateaued and was here. That's a situation that I don't think pushing more treatment to try to get MRD is really going to be effective. So that's when we have the discussion, well, you know what? You're not MRD negative, but you're not going to become MRD negative with this treatment. Perhaps we should just stop treatment. So that's really where this idea of fixed duration therapy and MRD is a meaningful endpoint. The question always is, chemotherapy, we did a pretty good job of getting MRD, but this is a trial that really compares the idea of Venetoclax-based fixed duration therapy or time-limited combination treatments versus standard chemoimmunotherapy. So that could be fludarabine, Cytoxan, Rituxan, or bendamustine, Rituxan in the frontline treatment. And basically, the important message here, these are MRD, undetectable minimal residual disease rates at month 15. So after these patients have completed their course of therapy, compared to standard chemoimmunotherapy versus Venetoclax-based therapy. And these are just different combinations of Venetoclax with rituximab, with obinutuzumab, plus ibrutinib. So different combinations. And importantly, you can see that the MRD rates, negativity rates, are much higher in the patients that got Venetoclax-based therapy than those that got chemotherapy. So I think this gives us more evidence that not only are the BTK inhibitors very effective as compared to chemotherapy, but Venetoclax-based therapies, even though it's fixed duration, is also very beneficial, especially when we're using deep remissions as an endpoint. And so in my mind, this just gives us more fodder to say, you know what, we're kind of phasing out chemotherapy in the fixed duration approach. So if I have patients that we're going to do ongoing therapy with a BTK inhibitor, we do that. Conversely, if I have patients that want to do fixed duration, there's really not a role of chemo anymore because we know that Venetoclax-based treatment is superior. And we see that in the trials of patients that we treat with Venetoclax and obinutuzumab. Remember, this is an antibody that binds to a molecule on the surface of the CLL cell called CD20, and in doing so, it activates the immune system to kill the cell. Well, this is over time. These patients all have disease. They're all MRD positive, which is what we expect. Not only the minimal residual disease positive, they've got that whole hay bale of disease. Now, over time, you can see basically this green represents patients that have undetectable MRD or no minimal residual disease. So we can't even find that needle in the haystack. And you can see a high percentage, even though this is a 15-month regimen or a year of combined therapy, a high percentage will be MRD negative at cycle 7. So I often, when checking this starting earlier on, so I can say, look, you're MRD negative, we can stop treatment. On the right panel here, you can see this is over time, patients how they do based on their status. So these are patients that we can't find that needle in a haystack. They're MRD negative on their, in this case, they use multicolor flow, but now we're using more of the next-gen sequencing or clonoSEQ. Over time, you can see undetectable MRD. Now, this just is a little different regimen. This is Venetoclax. This is another base regimen. But I think the important thing to note is if you're undetectable MRD, you have a superior outcome. These are patients that had low MRD, so still some MRD, but not large amounts, and they did a little better. And then this group had detectable MRD. And so you can see if you're still MRD positive, you can kind of counsel patients on this is what we expect moving forward. And this holds true with patients that have, this is just an update of what I showed you. And I think the key thing here is how do high-risk patients do with this? This helps me in understanding, do I want to do a BTK inhibitor or do I want to do this fixed duration therapy? And so I want you to focus on this blue line. This is an inferior treatment that we don't actually use anymore. But this blue line shows all the patients that have high-risk disease. Namely, they have P53 abnormalities or 17p deletion. So some of those high-risk markers. And you can see that their progression-free time was about 3 years. And that was, or in this case, you have 21 months versus 49 months of the different types of chemotherapy. But in patients that had Venetoclax-based therapy, their progression-free survival is 36 months in patients with higher risk disease. Importantly, also, if you look at mutated or unmutated, so remember, mutated is good risk, unmutated is poorer risk. You can see that patients that had a mutated IGHV at a follow-up of over 4 years, they have not met, not enough people have progressed to calculate a progression time. So fewer than 50% of the population has progressed at 4 years. Conversely, if you look at patients that have an unmutated IGHV, they have progressed already. So I think the bottom line of all of this talk is that Venetoclax fixed duration therapy is not as good in patients with high risk features as those with low risk features. And that is not a surprise, but that does influence what I'm recommending as far as my initial therapy, as far as fixed duration or not. And this also holds, I won't belabor this, but this also holds true in the relapse setting using Venetoclax and rituximab. Patients treated with chemotherapy had a much shorter remission time than those treated with Venetoclax rituximab. Those that were MRD, so what can we expect if you're MRD negative? If you're MRD negative and you're followed 3 years, your overall survival is 95%. And this is in the relapse setting, people had had many treatments. So the bottom line is Venetoclax best treatment or base treatment. If you're MRD negative, you have a longer remission. So what about patients that are MRD negative and have been treated with ibrutinib plus Venetoclax? So there is a combination treatment that does this. Can these patients be, how do they do? Do they have to stay on ibrutinib? Should they come off ibrutinib? And in this study was a study that took patients ibrutinib plus Venetoclax for combined treatment for a total of 15 months, which is kind of this, which has really become the standard of combination therapy, 15 months. And importantly, what it did is it didn't just look at the initial responses, it looked at patients, it then had another randomization. So if people had undetectable MRD, it randomized them to ongoing ibrutinib or placebo. If you had detectable MRD, you got ibrutinib and ibrutinib Venetoclax. But I really want to focus on these undetectable MRDs because, again, the question is, if I'm on an ibrutinib-based therapy with Venetoclax and I have an amazingly deep remission, no needle in a haystack, can I go off my ibrutinib and how will I do? And this does a nice job of answering that question. So if you have a really deep MRD negative remission on ibrutinib and Venetoclax, and I think we can extrapolate that to any Venetoclax or ibrutinib-based regimen, you don't need to continue therapy. You can stop the therapy. Even though this did not include a monoclonal antibody, this is the randomization. So these are the patients that continued on ibrutinib. These are the patients that continued on the placebo, the exact same rate of a disease-free period, And importantly, these patients are disease-free 30 months out. So a very good outcome. So how do I make sense of all this gobbledygook I've been talking about? Well, fixed duration and how do I use MRD in 2022? So I prefer the clonoSEQ platform, and mainly this is because it avoids the need for bone marrow biopsies in patients, and it's highly quantitative. It's just a blood test. Now remember, this has to be done prior to treatment. It also, and only for fixed duration therapy. I use it to inform, can I stop treatment early? Are there dynamic changes? And then in some cases, it informs at least the discussion, or should I continue therapy in high-risk patients, and are those who to continue have a response, and the response hasn't plateaued, even though the studies may say, well, you do this for a year, 15 months, you do this for 2 years, then you stop. This allows us to really personalize it for each patient. In my opinion, there's very little, if any, role for continuous surveillance or monitoring in the majority of patients outside of a clinical trial. So the clonoSEQ website, I would definitely recommend. This is Adaptive is a company that performs all of this. It's FDA approved for this indication. And they do a really nice job of explaining things. That said, they talk about, oh, you can do surveillance every 3 months. And I really do not see a need for surveillance in the setting, with the rare exception. So if patients have a history of autoimmune phenomenon leading to hemolytic anemia, that's where the body, in the presence of CLL, will inappropriately break down red cells, or they'll attack platelets. That can happen at very low levels of recurrent disease. So in those patients, we do have the discussion about, well, you know what, let's monitor your MRD status. And if you turn MRD positive, we may consider reinitiating treatment even though you've been off of it, because it may fuel this other disease complication. So I think, to summarize, I think watchful waiting is still the best option, unless it's on study, and we have that evolved CLL study for high-risk patients with high-risk CLL IPI. Any role for chemotherapy? Really, not really. And I actually have only used chemotherapy in patients that we haven't been able to get some of these more expensive medications for. And so I can count on one hand how many times I've used chemotherapy, definitely in the last 5 years, maybe the last 10 years. Ongoing treatment with single-agent BTK inhibitor, acalabrutinib is my BTK inhibitor of choice. Typically in combination is not needed. Perhaps we can do treatment interruptions. Again, no worries if you have to stop treatment for a period of time, but the general standard of care remains continuous therapy. MRD negativity is a good treatment goal for Venetoclax-based treatment. I like to use the clonoSEQ platform. And fixed duration therapy is a yes with Venetoclax-based treatment, really in patients with better risk disease based on the outcomes, the superior outcomes. So this is a very, so I can get there. This is a very stripped down, bare bones approach, my approach. There are much more detailed approaches, but I thought I would, especially at this point in the talk, leave it pretty simple. So my approach is, if patients have an unmutated IGHV, or they have a 17p deletion or p53 mutation, and or a complex karyotype, more than 3 abnormalities on their cytogenetics or FISH panel. And remember, these are all patients that meet the IWCLL treatment criteria. These are patients that I recommend acalabrutinib in frontline setting as continuous therapy. If they're intolerant and they've been on treatment for quite a while and their disease is under good control, I'm very comfortable observing and retreating when needed. If their disease is not under good control yet, or the patient really wants to continue to pursue treatment and we've got a ways to go, then we go with ibrutinib. Or if they're intolerant then to ibrutinib, then we consider Venetoclax. Conversely, if someone progresses, we go to Venetoclax. Now, what's not shown here is, option number 1, in my opinion, should be clinical trial. Option number 2, at progression, should be clinical trial, et cetera, et cetera. For patients that have better risk disease, so they have a mutated IGHV, they don't have a complex karyotype, they don't have 17p deletion or p53 mutation, and they don't have major cardiac risk factors. So this has become more front and center with high blood pressure, atrial fibrillation, history of heart failure, history of multiple heart attacks. I'm much more cautious using BTK inhibitors in those patients now, because we do have increased morbidity and in some cases mortality when we use some of these drugs. So that has to be looked at very closely in certain populations. But in those patients, I'll do some clonoSEQ testing at baseline so we can get an MRD signature. Then we'll start Venetoclax-based treatment, and it's typically in combination with obinutuzumab. So Venetoclax-Gazyva or Venetoclax-obinutuzumab, that's the same thing. At month 6, 9, and 12, we will do clonoSEQ testing. If we're MRD negative, we will stop. At the end of treatment, we will do it as well, just to kind of understand, are we seeing the changes I mentioned? If someone's intolerant, we do the same thing, observation, or we switch to a BTK inhibitor. If progression, we switch to a BTK inhibitor. So that's the general approach I'm taking when I'm talking to a patient about treatment. So just a couple things about some very exciting developments. So when BTK inhibitors first came out and we would apply for grants in CLL, we would always, we were saying, oh, we have new therapies. And at that time, we would never get the grants because these drugs were so effective. Now, as is often the case, the disease is starting to outsmart some of our drugs, including ibrutinib, acalabrutinib, and venetoclax through pretty well-known resistance mechanisms. And in particular, acalabrutinib and ibrutinib, you develop resistance. It's kind of thinking it as a lock and key. So this is the area where these drugs all bind: zanubrutinib, acalabrutinib, ibrutinib. This is the energy pocket of this enzyme. And there's a certain mutation that develops, C481S mutations, where you get an amino acid, that one amino acid replaces another amino acid. And what it does is it causes a conformational change. So if it's like this, you get that mutation at the binding pocket and it goes like this. So the drug can't fit in there effectively. And that just happens over time with selective pressure, almost like the idea of antibiotic resistance. Well, when that happens, it renders these drugs much less effective. You can also get mutations in a downstream signaling molecule in the B cell called phospholipase C gamma 2. So the question is, are there BTK inhibitors we can employ that actually can work effectively in these patients? And the answer is yes. So pirtobrutinib or LOXO305 and ARQ531 and becabrutinib, they target BTK, but at a different site. So they work even in patients that have developed this mutation. So this is the Bruin study that looked at this pirtobrutinib. This is called a waterfall plot. Anything below the line is tumor reduction. So oftentimes in early phase trials, when we're just trying to understand responses, you can see these patients had very good reductions in their CLL disease burden. And also these dark bars are these patients that progressed on other BTK inhibitors. So it shows that if you find a different target at that enzyme, a different lock and key mechanism, you can still be effective. Here's an example that these are patients that had progressed on previous or had been treated before with BTK and venetoclax, BTK inhibitors and venetoclax. And although follow-up is short, it's very encouraging because, again, it's working in patients that have failed prior BTK inhibitors. And it's very effective in patients who develop BTK inhibitor mutations on ibrutinib and acalabrutinib. And it's very well tolerated. Unlike some of the others, it has a very low risk of atrial fibrillation and hypertension. So we're very excited about this. All right. So switching gears, we're almost to the finish line here. So as most of you know on the call, and we've all been very frightened together during the COVID pandemic. And early on, there were two studies, one from the United States and one internationally, that really looked at COVID outcomes in CLL patients based on being immunocompromised. And in those studies, 70–90% of people were hospitalized with COVID, and about a third of them died from COVID. This was all pre-vaccine. And we know that advanced age and comorbidities increase the risk for death. The other thing we know is that because of impaired immunity, patients may have active infection for months or difficulty clearing the virus. My record thus far is a patient followed outpatient for 5 months with active infection, intermittent fevers, cough, and just never developed antibodies and couldn't clear the infection. And that can be problematic for a number of reasons, obviously for the patient, but it kind of becomes a little incubator for new variants. We do know that survival in CLL patients has improved significantly over the course of the pandemic. And this is even the pre-vaccine. So there's a study that was published that looked at the first 6 months of the pandemic and then the next 6 months of the pandemic, and definitely improved outcomes over the course. And that's due to treatments, that's due to early recognition and testing. So what about the vaccines? We were also excited to see these vaccines come through, but like many vaccines in CLL, the antibody response rate is lower, and on average about 40% with the initial series, and a real broad range, heterogeneous response, 15% to 80%, and that really was the ability to develop antibodies, and it was associated with, if you had a poor antibody response, that's if you had a low immunoglobulin level, if you had ongoing acalabrutinib or ibrutinib, or if you had had rituximab or obinutuzumab within 1 year. And that really makes sense because it decreases your B cells and impairs their function, not just the cancerous B cells. And then also there was a publication that showed that this was improved with the third dose. So we could boost that up by 25%. So we've done actually a lot of work in this area, and I want to just credit, I've been working with a graduate student on this who's done an outstanding work, and then with a lab technician named here who generated these data. And so this just shows over time what we're looking at. So the RBD is a part of the spike protein. And what we see, this is pre-vaccine, this is pre-vaccine, and these are the initial group of patients that got the vaccine. You can see some didn't respond very well, but these are patients that had some response. Then we added more patients to the cohort, and we gave them additional vaccines. And you can see between vaccine, so this is this is draw 3 before their third vaccine, this is after the third vaccine. You can see a significant boost for the majority of these patients. So that just shows that, yes, the boost is necessary. The question is, and persistent over time. So this is at draw 5, usually 3 months after draw 4. So persistence over time. So what about the fourth dose? Well, these are patients that got 4th doses, and here you can see a patient that actually salvaged a response after the 4th dose, and this patient had an increase after the 4th dose. So I think the message here that we want to make sure everyone has had their full booster. There is not yet a role or data for a 5th dose. We don't know that yet, with some caveats, and I'll explain those in a second. So what we were able to see that even in patients, many of whom didn't seroconvert at the beginning, meaning they had no antibodies, with additional vaccines, additional 75% seroconverted. These are T cell responses. So T cells are also part of the immune system, and they also went out more robustly after the initial 2, but did have some increases after subsequent vaccines. So there are different types of T cells and had good responses. And these are neutralizing. So if you incubate these antibodies with different strains of the virus, they do neutralize the virus. So how does this translate into my everyday? So my approach in this setting, we have a lot more levers to pull now. So as far as prevention, vaccine early and often. So 4 doses of the vaccine. Now this is the caveat. Many of the patients got vaccinated early on active treatment. We were just trying to get everyone vaccinated. We didn't know exactly what we were dealing with. I revaccinate all patients, including boosters, and anyone who's gotten Rituxan or Gazyva within 12 months. So if you got 3 or 4 vaccines, and that was all within a year of obinutuzumab or rituximab, or even BTK inhibitors, well, it's time to start over with your vaccines, the full 4-dose series. Now we also have Evusheld, which you have to be fairly aggressive to find it, but I give this antibody treatment. It's given in each buttock as an injection that within 14 days, people achieve high antibody levels, and it lasts for 5.5 additional months for added protection, and it decreased hospitalization and serious and poor outcomes. And so I give it to people that are on active treatment. So that includes ibrutinib, acalabrutinib, or people within 12 months of Rituxan or inotuzumab. And I do give it in an observation patients, but I check their antibodies first to see if they really need it or benefit from it, because this is a fixed resource. What about treatment for COVID? Well, now we have Paxlovid. I think the key thing here is starting it within 5 days. Remember that the rapid antigen test at home may not be as sensitive. So typically I tell my patients the first day, check a rapid test. If it's positive, then you can go get Paxlovid. If the second day it is it's still not positive, make sure you get a low threshold for a PCR test. And then we also have bebtelovimab, which is an injection, monoclonal antibody. This is actually much harder to come by. So typically Paxlovid is our first line of defense. But some patients may not be eligible due to drug interactions or kidney disease or liver disease for Paxlovid, or they're outside the 5-day window. It has to be administered within 7 days. All right, I know we covered a lot of information. I hope that we have some questions. I think moving forward, I know some patients may have questions about CAR-NK or CAR T-cell therapy or immunotherapy, but that's really the way of the future. Thank you for your attention.
Thank you. Thank you so much, Doctor. It's now time for our question and answer session. For everyone's benefit, please keep your questions general in nature without many personal details. Operator, can you please give instructions to our telephone and web audiences?
Thanks. If connected by telephone, press *1 on your telephone keypad to queue up for a question. Press *2 on your telephone keypad to remove your question from the queue. If connected via the webcast, just keep typing your questions in the Ask a Question field on the left side of your screen. Thank you.
Thank you. And Doctor, you had mentioned about CAR T. Well, Roy is asking, what is the applicability of CAR T or CAR NK therapies to CLL? Do the lymphocytes have a characteristic protein that can be targeted?
Yes, thanks for that question. Basically, CAR T is highly applicable to CLL or any lymphoid malignancy. The nice part about CAR T is you can target any target on a cell. And so there are new targets developing all the time, but classically it's against a protein called CD19 or CD20. They're not FDA approved in this population yet, but there are a number of clinical trials. The CAR NK is not as far along as far as its development, but the nice part about CAR NK is that actually it can just be off the shelf, meaning it's not as, you're not as worried about rejecting the NK cell because it doesn't have some of the immune features that would cause the body to reject it. So it's definitely a very promising treatment. Right now, it's really, this technology and treatment is really reserved for people with multiply relapsed disease who have failed the treatments I already mentioned, and it's available on clinical trials.
Thank you. And we'll take the next question from our telephone audience, please.
This question comes from Kathy, calling from California. Please go ahead.
After taking acalabrutinib and Gazyva, how long does the drug work to keep the blood count, the white cells, low?
Yeah, so I think it depends. So typically with acalabrutinib and Gazyva, people stay on acalabrutinib. And if you look at 5 years down the line, about 60 to 70% of people are still on treatment. It's a little less clear if people take acalabrutinib and Gazyva and then stop it, because it's, it depends how in-depth their response is. But generally, we think about long-lasting remissions, beyond 5 years.
Thank you. And Lawrence is asking, are antibodies for shingles, pneumonia, COVID, etc., lost during CLL drug treatments if vaccinations were given before treatment began?
It's actually that's a really good question that we don't have a great answer. So it depends on the situation. So some antibodies are incredibly long-lived. The classic example is measles. So when we checked measles in measles antibodies in patients, about 80% still had measles antibodies, late into their life. But what we found is with the treatment that really diminished the cells that can make new antibodies. So what that means is that some patients will lose the antibodies like COVID antibodies and lose the ability to make new antibodies. But most of the childhood things, they will persist for a long time. The exception is shingles, and that's why we ask people to get the shingles. Those are given, assuming someone has a good response, they really will be fairly persistent.
Thank you. And we'll take the next question from our telephone audience, please.
Our next question comes from Patricia, calling from Pennsylvania. Please go ahead.
Hi, I was just wondering, has anyone experienced hair loss while on acalabrutinib?
So it's not why. To be honest, the answer is yes. I think it's always the question: is it acalabrutinib related? And that is not that well understood. Although the classic thing is so yes, you can experience a little hair loss. The classic thing is a lot of nail changes as well. I don't know if anyone has run into that.
Thank you for the question. And our next question, Bruce is asking, what's the best way to manage fatigue? I know that Patricia is also asking about fatigue as well as others.
So there are a lot of different approaches there, and it really depends on the situation. So if fatigue is from the disease and progressive disease, it's really treating the disease. I think a lot of times we get in this no man's land of going to the doctor and saying, oh, your disease is stable, you don't need treatment, but people having fatigue. I think the best data for cancer-related fatigue is exercise, and that has held true across a number of different types of cancer. Otherwise, though, it's making sure that primary care physicians don't say that people's symptoms are related to their CLL, and just making sure that you have a comprehensive workup for things like depression, sleep apnea, cardiac abnormalities. Sometimes in patients undergoing treatment who have treatment-related fatigue as well, sometimes we will go to stimulants like Provigil or Ritalin-based treatments. But that's probably the exception, not the rule, and it's just ruling out some of these other things as well.
Thank you. The next question from Wilma, she's asking, I've been on ibrutinib for 5 years. How will I know if I'm in remission?
So that's a really good question as well. I think there are different degrees of remission. So if you're still on ibrutinib and your blood counts are normal and you don't have enlarged lymph nodes on exam and you're feeling well, you're in remission. This is not something that we typically do a lot of CT scans for or additional testing. Now, that said, if you did get to the point you said, gosh, I want to maybe come off the drug or understand how deep my remission is, then you can talk to your doctor about doing things like bone marrow biopsies and looking for MRD status. But at this point, I would not recommend that. I would say if you're tolerating it and doing well, again, not knowing your case fully, but that the general standard would be staying on the drug, and as long as you have normal counts and are doing well.
Thank you. And doctor, we want to know what you're most excited about with all of the new therapies that are coming out recently for CLL.
Yeah, so I think so the pirtobrutinib approach, new BTK inhibitors, I'm very excited about because it also shows that we can work to outsmart the disease, employing well-known targets already, but just drugging them differently. And there are also other signaling inhibitors that I didn't discuss today, other oral drugs that are highly effective. But I'm very excited about these bispecific antibodies. So bispecific antibodies are basically drugs that come in and they form as a link between your good immune cells, your T cells, and the cancer cells. And basically what will happen is it'll sit there, the drug, and it'll have your cancer cell here, and it'll come in here and bring the T cell in here, and it tells the T cell to kill the cancer cell. And we're had a flood of activity related to that, and that's proving to be highly effective. So it's kind of like the idea of using the targets that we know are effective with rituximab and obinutuzumab, but in a different way to harness the body's own immune system. And we've seen just outstanding responses. And then I'm I don't know if excited is the right word, but I'm pleased or cautiously optimistic to see what we have, our better understanding of COVID and more options for our patients that have been, so careful over the couple of years, and being able to see grandkids and celebrate with family members. I think hopefully we can move ahead with that as well.
Thank you. Yes, we totally agree. And we did have a lot of questions today in regards to COVID. And thank you for the discussion in your slides in regards to COVID today. And thank you again, Dr. Spurgeon, for sharing your expertise with us and for your continued dedication to our blood cancer patients. So we had many questions today. And I know that we weren't able to get to all of your questions. You can definitely call an information specialist at the Leukemia and Lymphoma Society at 1-800-955-4572. We're open from 9 a.m. to 9 p.m. Eastern Time, or you can go on our website at lls.org/information specialist to chat online, or email them at lls.org/contact us. We also have information about COVID-19 on our website at lls.org/coronavirus. Our Clinical Trial Support Center has clinical trial nurse navigators who will personally assist you throughout the entire clinical trial process. I know that Dr. Spurgeon did mention clinical trials, and you may reach out to them at lls.org/navigation to see if a clinical trial is something that is in your future or is available to you right now. Again, we'd like to acknowledge and thank Genentech, Inc. and Biogen, Eli Lilly and Company, and Pharmacyclics, an AbbVie company, and Janssen Biotech. Website participants, please complete the program evaluation, which will appear at the conclusion of this presentation. Phone participants can complete the evaluation at www.llseval.org or complete the form included in your packet. You will be entered to win a gift card. Again, Dr. Spurgeon, thank you for sharing your expertise with us and your time with us today. And on behalf of the Leukemia and Lymphoma Society, thank you all for joining us for this program. And please let us know what you need from us during this time. We hope to have you as well as your caregivers on next month to address caregiver issues. Thank you and take good care.
Thank you.
Thank you. This concludes today's telephone and web education program. You may disconnect your lines at this time. Thank you for your participation.